Can you see my slides okay?
Yep.
All right, I've been asked to talk about what's new in radiosurgery, so this has actually been fun to put this talk together, and I want to thank the organizers for the invitation to be part of this great symposium. I'll do my best to get us back on track, although I really enjoyed that discussion. I just want to first start by saying that, spine radiosurgery is coming into its own right now. There's, a quarter of a century of now published experience with radiosurgery in the spine. There are now maturing prospective randomized trials that have been completed or being reported. So this is really a new era in radiosurgery of spine disease. So, for example, if you take a quick look at the NCI website and just do a very simple search looking for ongoing clinical, a lot of academic interest in various aspects of radiosurgery for the spine. So it's really an exciting time to be involved in this field. Let me just give you one example of a prospective trial, which I'm familiar with because we were the lead institution in this multinational randomized trial of oligometastatic disease. Oligometastatic typically meaning between no more than 3 to 5 metastases in most definitions. For this clinical trial, we allowed up to 5 metastases in a patient, and they were given either 24 gray in a single fraction or 9 gray times 3. And similar to many other prospective trials in this arena of oligometastatic disease, we found that aggressive local treatment of limited metastases has significant benefits. First of all, in terms of local control, I don't think anybody's surprised to see that single fraction radiosurgery 24 gray provides superior local control of treated lesions. But what was really interesting to us was that it actually had an impact on the likelihood of developing new metastases. So in the oligometastatic setting, the more ablative or effective local therapy results in a reduced risk of developing new metastases. And in fact, some oligometastatic trials have even shown a survival advantage for more definitive treatment of limited metastases with SBRT type of radiation. I don't need to harp on this slide much more because we've already had a very nice discussion on it. Just to say that, moving beyond metastatic disease, I think that radiosurgery is now a potential a good consideration for treating primary tumors of the spine. And so moving just beyond metastatic disease, but going into the realm of primary tumors. And I didn't have a slide on this, but even in the setting of benign tumors of the spine, there's increasing evidence suggesting that radiosurgery is a very viable option for benign tumors in the spine. So even moving beyond outside of the realm of oncology and into benign tumors. And now what I want to talk about a little bit is moving outside of tumors altogether. And so is there a role for radiosurgery in more so in the functional sense? And so I just want to introduce a small pilot study that we're starting at our institution for patients who have chronic back pain. And as we know, it's one of the biggest healthcare challenges in our country. There are many different options for them. Many work, many don't. Sometimes it's hard to predict what's going to work and what's not going to work for these patients. And certainly failed back syndrome is from what I understand, is the largest consumer of Medicare dollars in the United States. But could there be a role for radiosurgery as part of the treatment paradigm for these patients who suffer terribly from back pain that cannot be well managed? And to do that, I'm going to suggest that we look to the experience of using radiosurgery for trigeminal neuralgia. If you can dose escalate to above 90 gray in a single fraction, these patients can often get excellent palliation of an otherwise difficult condition to medically palliate. And so this is just one of many experiences showing that if you can get an appropriate dose to the trigeminal nerve, that you can actually get very good, durable palliation of pain for patients who suffer from trigeminal neuralgia. So our thought was, could we take the same paradigm and apply it in patients who suffer from back pain? And it's actually very easy to see the dorsal root ganglion, even on our traditional simulation CT scans using a 2 millimeter slice thickness. This is actually a patient that we simulated for radiosurgery, but just to point out, you can actually see the dorsal root ganglion, which could be a good target for radiosurgical ablation to help with back pain management. And so what we are proposing is to do a radiosurgery and we're going to do a dose escalation study for patients who have chronic chest wall pain. And the idea is to go do dose escalation up to 90 gray in a single fraction in a standard 3x3 dose escalation study format as a pilot study. This has actually been tried before. We're certainly not the only ones who thought of this. And so this is actually a single patient report of a patient who suffered from occipital neuralgia, got 80 gray in a single fraction, and had good durable palliation. So this is actually something that's already clinically been tried. And this is an early study from the Stanford group, from John Adler's group, using CyberKnife to treat facetogenic back pain. And what they found was that 3 out of 5 patients were able to achieve pain relief in this very small case series. The problem, although linear accelerators have been used to treat trigeminal neuralgia cranially, we always have to use special attachments called cones to try to reduce the penumbra that you get when the radiation source is farther away. And cones can kind of focus the radiation a little more tightly, and that's wonderful to use in the cranium. But the cones actually will collide with the torso if you try to do this in the spine for a spine. And so we've, in collaboration with the University of Alabama, come up with a new technique to treat these small targets around the dorsal root ganglion using what's called a virtual cone. And the way we do that is to shoot through a very small aperture, a 5 by 2.1 millimeter aperture, with the collimators at plus and minus 45 degrees, and use a rotational arc approach where the linear accelerator rotates around the isocenter set at the target. Very small fields. And using this kind of arc approach, we've actually shown that you can get the same kind of dose profile that you would get with Gamma knife. And this can be done without using a Gamma knife, without using a cone, but by using this virtual technique, get the same kind of dose profile for treating very small targets, in this case, 4 to 5 millimeter targets. And so this allowed us to have enough confidence to say that, we could actually, this is feasible in a patient. So this is actually a phantom, not a real patient, but showing the kind of dose distributions we can get and giving up to 90 gray while keeping within our dose constraints that we typically use for radiosurgery, especially around the spinal cord. That's really important that we get those relatively low dose rates, even though the nearby targets will be getting up to 90 gray. So here's an example of a dose volume histogram of a study case showing that it's feasible to keep the cord well within dose tolerance by still giving the targets the sufficient dose that we think will be necessary. So like I said, this is going to be a 3-dose tier pilot study that's just about to open. And so I just wanted to give you an idea of, what in terms of what's new for radiosurgery. We may be able to find effective indications that are never mind metastasis, or never mind primary disease, or even benign tumors in the spine, but even patients who have no tumors and really going into more functional type of radiosurgery in the spine. The last thing I want to talk about is developing proton beam based stereotactic radiosurgery for spine tumors. There are a lot of good reasons why this hasn't been done. Proton beams are particularly finicky, and although they have the famous Bragg peak effect, this is a double-edged sword, and it's very difficult to know exactly where the Bragg peak effect happens. There's a lot of uncertainty. And so in the past, people have been very careful about wanting to give the entire course of radiation in a single session using protons, because there's so many factors that can result in having the radiation deposited in a way that you hadn't intended. There are some significant biologic benefits. There are dosimetric benefits like the Bragg peak, which I don't think I have to really explain to this audience. But one of the interesting aspects is this idea of a linear energy transfer. On the back end of the Bragg peak, if you would imagine a car braking to a stop, most of the kinetic energy is absorbed as the car is coming just to a stop. In the same way, there's a much higher amount of energy transferred per unit length as the proton is stopping at the back end of the Bragg peak. And that theoretically results in a higher biologic impact. And this can have some really important implications in terms of making proton-based treatment more immunogenic, for example, in the setting of checkpoint inhibitors. So there are not only just dosimetric advantages of protons, but there could be radiobiologic advantages to protons that we should look at, and may be accentuated in the setting of giving the entire course of radiation in a single session. And one of the most interesting observations is this so-called flash effect. And this is ultra high dose radiation delivered up to 40 times per second faster than conventional radiation. So in flash radiation, instead of taking minutes to deliver a course of radiation, the radiation is given in seconds or even tenths of seconds. And what's been known for a long time is that if you give an equivalent dose of radiation in this ultra high dose way, that there's significant normal tissue sparing even at the same delivered dose of radiation. For example, lung fibrosis is a well-known complication of radiation. If you give 17 gray using flash techniques, so in tenths of a second, there's minimal fibrosis in the lung compared to 17 gray given at a conventional dose rate. And in fact, in experimental models, 30 gray of flash effect is required to get the same kind of fibrosis that you would get with just 17 gray with conventional dose rate radiation, which means that you can essentially double the dose of radiation and have the same potential probability of toxicity. And this has been shown in many tissues, in animal models, in the lung, in the brain, and in the abdomen, suggesting that this flash effect seems to be universal across all types of normal tissues throughout the body. And so you might wonder, well, if that has some kind of dose-sparing effect in normal tissues, would you see the same effect in tumors, which actually would be very counterproductive? But actually, in animal models, what's really interesting is that whether you give the radiation in a flash, ultra-high dose manner or in conventional radiation, although it's significantly toxicity sparing for normal tissue, there's no tumor sparing effect with using a flash approach. And so this is really a really interesting opportunity for dose escalation, for example. If you can give the radiation this quickly, you can increase the radiation dose, sometimes doubling the radiation dose without increasing the toxicity, provided you do it in a flash type of technique. And so here are a number of preclinical models that have found in different types of implanted tumors that there is no sacrifice of tumor control with equivalent physical radiation dose, with the only difference being how quickly you give it. And so proton therapy is actually one of the most, it's actually one of the easiest ways to do flash radiation. It is a technology that allows us to give high doses of radiation in tenths of a second, which current linear accelerator-based technology is simply not capable of doing. And so proton beam radiation could be a very intriguing way to do stereotactic radiosurgery in the spine, because there's clear dosimetric advantages by taking advantage of the Bragg peak effect of sparing. For example, the anterior structure like the esophagus will get significant sparing just from the Bragg peak effect. But there could be radiobiologic advantages of using protons because, for example, there's a higher linear dose deposition with protons on the back of the Bragg peak. And these kinds of dose spikes within the tumor may be important for increasing the immune system ability to react against irradiated tumor cells. And as I was explaining, with flash techniques, there could be significantly less toxicity and without sacrificing tumor control. So for example, a clinical scenario where flash-based proton radiosurgery may be really important is in recurrent tumors that have been previously irradiated, where you may be able to very safely give definitive doses of radiation, taking advantage of all the potential benefits that proton beam radiation has to offer. There are, as we discussed in a discussion before my talk, some challenges. There are a lot of uncertainties still associated, what to do, making sure that everything is timed properly, that the conditions for radiosurgery are completely predictable. Getting rid of the titanium hardware, I think, is going to be an important part of making this successful. And improve ways to monitor patient motion will be important. But motion, uncertainties may be resolved by just giving the radiation so fast. And of course, treatment planning will have to be adopted to more of an IMRT style planning, I think, in order to get the appropriate dose distributions that we'll need to do this safely. So, what's new in radiosurgery? Well, there's all kinds of things going on. I think we're in a new era where radiosurgery is really becoming mainstream with increasing clinical experience with randomized prospective trials now available. But now even moving beyond metastatic disease, beyond primary tumors, beyond benign tumors of the spine, and moving beyond any tumors towards more functional radiosurgery, I think will be an exciting area. And then proton-based radiosurgery, I think this is something that we hope and we think has huge potential in adding important tools to our armamentarium and managing patients who often have otherwise very complex clinical problems. So I think I'll stop there, and thank you so much for your attention.
So, Josh, that was terrific. Thank you so much for all the hard work, and both you and Mark, I think, have really sort of exemplified the multimodal, theme and kind of what we've tried to do in this conference. I do think, tumor treatment really needs to be tailored for the pathology. And I do think, the type of radiation, the timing, the surgical approach, all those things are extremely thoughtful. And I think also, in my experience in our center too, I think having a team, and having different expertise, and we have orthopedic surgeons, neurosurgeons, radiation oncologists. We actually have a neuro-oncologist in our center as well. I know you guys do too. I think having this collaborative approach is really important. And do you guys have, just on this subject, Josh, how do you guys present patients? Is it like a weekly conference where you and the rest of the team review cases? How are you guys structuring your care?
Yeah, we have several points of contact throughout the week. That are regular points of contact. We have 3 teams of spine surgeons and radiation oncologists that have clinics together. Since COVID, they've become more virtual than actual physical, and that's we look forward to doing more physical. But I'm actually having a hard time getting my patients to come in anymore. But Mark and I have a combined spine clinic, which we actually share with our kyphoplasty team and physiatry. On Tuesday mornings, we have a kind of a system-wide contour review conference where all our spine SBRT contours are reviewed together with neurosurgery and radiation oncology. And so that's throughout all our satellite centers as well as the main hospital. All those cases are reviewed together. And we have an automated treatment planning algorithm so that it doesn't matter where the patient is simulated or planned, or it's all the same plan. It's the contours that make a difference. And so that's a second point of contact to kind of ensure quality throughout the entire system. And then we have 2 other spine surgeons that have clinics together with corresponding radiation oncology throughout the week. And then we also have a phone number. I don't know, sort of like 1-800-SPINE, where any medical oncologist can get in touch with somebody on the spine team, whether it's a surgeon or radiation oncologist. They have an urgent spine problem clinic. We can disposition that with an email or over the phone. And so I don't know, Mark, are there any more? Have I missed anything?
No, I think you're spot on.
Oh, and spine conference. I forgot about our tumor board, which meets weekly. And it's a spine-specific tumor board. And that is, involves, as yours does, it's, orthopedic surgeons, neuroradiologists, physiatrists, as well as radiation and neurosurgery. And we also have an interventional pain team that's also part of that tumor board.
Roger, we're kind of spoiled because they let us become a service line in the hospital. So spine tumors are actually a service line. And we went back to look at a couple of weeks. We see about 70 to 80 spine tumor patients a week. And then we see about 15 inpatient consults that are acute. And so there's this ability to do multidisciplinary on the fly because we're completely integrated. So there's always somebody on call from neurosurgery, radiation, and their sole responsibility are spine tumors. And that's why, it works. I think the biggest thing for us was the multidisciplinary clinic where we could disposition so quickly. And then we could troubleshoot problems really quickly. So we saw stuff wasn't working. We could almost change on the fly and then go back and look at that patient population, things like fractures after radiation or why we needed perk screws for some of these patients with instability alone really became very clear in clinic because we were seeing these same patients over and over as a group and everybody had a different expertise. And that's been the godsend. And then I think The other thing, we're very fortunate. There's not a better partner in the world than Josh, and we all have felt very fortunate. We all sort of started this together, and we had no ego. It was just we have no idea what the right answer is, but we're going to get there together. And the Grace has been doing this with Josh and Eric Bliss and Ilya, and that's really been the grace of this effort.
Mark and Josh, do you have a medical oncology on your tumor board? I mean, sometimes I find it's difficult to get these guys. We can get radiation oncology, the spine surgeons, but medical oncology, because they are very patient specific, it's hard to get them the specific medical oncologies for your spine tumor board. How do you handle that?
Yeah, I think for the only place it really plays a huge role in the treatment of the specific spine tumor is myeloma and lymphoma.
Yeah. So
they can come to tumor, but most of it is done virtually before they ever get there, so that we see where they are and what their needs are and where they think they are in terms of extended disease. I'd say the vast majority of the time, Josh, they don't really come. The exception is NF. We have a massive NF effort as well, and there we have 3 neuro-oncologists who almost virtually do nothing but NF, but that's a very specific, obviously, and neurospecific. So, yeah.
I think, I think that's the same kind of challenge everywhere, Udi, that you mentioned. And one way that we got around that is that, we'll do presentations and kind of go over the NOMS framework in medical grand rounds. And then, as we were alluding to before, just instead of having to have a medical oncologist trying to figure out somebody's spine problem, our solution is just send them to us, and we will disposition your patient for you. We'll take care of your patient's spine problems, and you won't have to worry about it. It's been our line, and I think people have really taken to that. And so they know, and now with experience, they've come to trust, our evaluations, and we always include the medical oncologist in what we're going to do. But it's sometimes easier to just have them send us the patient, and then we'll just take care of it for them. Kind of approach, I think, has worked relatively well. And so, communication. Having something like the NOMS framework that Ilya explained, where everybody speaks a common lexicon and is a very useful vehicle for that kind of communication, has also been, I think, key in having different parts of the team communicate in a way that everybody understands each other.
How many radiation oncologists do you have on your team that do radiosurgery, and what kind of training do they have to have in order to be able to do that?
I think we have about 30 throughout the whole system that are treat with spine SBRT. We actually have more cases treated out in our regional network than at the main hospital. Okay. And they all go through a credentialing process. And so they go through like a mini training program. And then we ask them that they present their cases with us, so that they're not kind of doing their own thing, and that they have to have a minimum caseload to keep their credentialing. Is how we've set it up. And we've actually done a study looking at our outcomes in the regional network, where the vast majority of our attendings are, compared to the main campus, where there's only 3 of us. And our outcomes are no different in terms of tumor control or toxicity.
Dr. Yamada, quick question. Do you guys have some kind of chart rounds or QA review rounds regarding the radiosurgery plans from the satellites?
Well, because it's all an automated, there's no human input anymore on our plans. And so it doesn't matter whose desktop you run the plan on, they're exactly the same. And because we have fairly stringent criteria on what's acceptable and what's not, they do go through a chart rounds, but if there's any problems or questions that an attending might have, let's say somebody who's just starting out and they're worried about what the plan looks like, we often just discuss it on a case-by-case basis. And so there's no chart round specific to the quality of the plan, because the plans are all they're uniform, because it's all done by an automated algorithm now.
Yeah, I think the other thing that's so great that Josh set up was contour review. So everything that's being treated on radiosurgery before it goes to planning gets contour review centrally, so that everybody with experience, and if you're inexperienced at all, those contours all look the same, and that's been so critical, in terms of QA and such. Yeah.
So it's really the contours that will drive the plan. And so if the contours are going to be the same regardless of who's doing it, that's our goal, because the planning will really be based on what the computer receives in terms of contours.
And if there's a relatively urgent case, are the contour reviews done in relative real time, or do you wait for kind of a certain time for everyone to?
Yeah, if it's urgent, like we have an expedited program for patients who need to have, urgent radiosurgery, so to speak. Then that's just done on a case-by-case basis with whoever's available to do the review.
Great. Thanks so much, Josh. And really appreciate you getting involved in this course, and your insight and your experience is tremendous, and look forward to seeing you again in the near future.
Thank you.